This is Brent of the Brookbush Institute, and in this video we're bringing you another manual technique. Now if you're watching this video, I'm assuming you're watching it for educational purposes and that you are a licensed manual therapist following the laws regarding scope of practice in your state or region. That means athletic trainers, chiropractors, physical therapists, osteopaths, licensed massage therapists. You are likely in the clear to do these techniques. Personal trainers, this probably does not fall within your scope of practice, although you might be able to use the palpation portion of this video to aid in learning your functional anatomy in an educational setting supervised by a licensed manual therapist. Now, before we place our hands on a patient or client, it is important that we assess and have a good rationale for doing so. And of course, if we're going to assess, then we should be reassessing to ensure that the manual technique we're using is effective and we have a good rationale for continuing to use that technique. In this video, we're going to go over static manual release of our suboccipital muscles. That's our rectus capitis posterior major, rectus capitis posterior minor, our obliquus capitis superior, or obliquus capitis inferior. If that wasn't enough of a mouthful, I know a few of you are so familiar with your suboccipital muscles, you're wondering where the rectus capitis anterior and rectus capitis lateralis are. Those muscles are too deep to actually be palpated and probably fall anterior to the axis of rotation for the upper cervical spine, making them deep cervical flexors. So our rectus capitis anterior, rectus capitis lateralis, we're going to go ahead and say that they're included in deep cervical flexor activation. What we're going to work on this video is release of the posterior suboccipital muscles. I'm going to have my friend Melissa come out. She's going to help me demonstrate this technique. Now she's going to start lying face down so I can kind of point out some landmarks, although we'll do this technique face up. I should mention right off the bat that it's probably not a reliable palpation, or it's not possible to reliably differentiate between the various suboccipital muscles. Unfortunately, these muscles are very small, they're kind of hidden away, and they're deep to two larger muscles of the neck, being the upper trapezius and spleniae muscles. But if I think about my anatomy a little bit, I think that we can set up some borders, especially with the obliquus muscles, that'll give us an idea of where we should put our thumbs to release these muscles as a group. So my obliquus capitis inferior goes from the spinous process of C2 to the transverse processes of C1. So C2 is the first spinous process you can feel underneath the skull. The transverse process of C1 is just inferior and posterior to the mastoid process. Yes, that point that the skull comes down to right here, right behind your ear. If you go just inferior and posterior to that, you can actually feel your transverse process sticking out, right? It definitely feels like bone and not soft tissue. You can't press all the way through it. You press through a little soft tissue where it is, and all of a sudden, boom, you hit a hard little point. So put your finger on that transverse process. Put the other finger on the spinous process of C2. That's going to be the inferior border of our suboccipital muscles. Now my obliquus capitis superior goes from transverse process of C1 to inferior nuchal line. That's our outer border. So we can honestly say just that transverse process we just found, if we just go just medial to that, that's going to be our outer border. Our superior border is going to be this inferior nuchal line, and you guys can feel that by just going just underneath the base of the skull here into the soft tissues. I think you'll feel that ledge, right, where all of a sudden you palpate right into some pretty dense tissues. That's going to be our suboccipitals. So we got our borders drawn out here. That's how we're going to palpate these muscles. Before we go any further with this technique though, I'm going to have Melissa flip over and be face up, because this just isn't a very comfortable way to get a release to happen. There's an easier way to do this, which is I can go just like this. I can do that curling of the fingers technique and let the weight of Melissa's head do all of the work. Not to mention I have a little bit more control over lateral flexion, flexion extension, which may help me when I start trying to palpate for dense fascicles. So I'm going to start with one side at a time. Once again, I'm going to find I'm going to find that transverse process of C1, I'm going to find C2, I'm going to let my fingers fall in. A little trick here you can use, guys, is if I go into a little bit of upper cervical flexion, which is going to be like a chin tuck, and it's probably helpful to think of like a chin tuck while retracting, and then I go into a little contralateral flexion. I've now lengthened those tissues quite a bit, and then I can actually experiment with either contralateral rotation or ipsilateral rotation to try to further allow me to find dense fascicles into an area that's actually not going to allow me to strum. I know in a lot of our other videos we've talked about strumming the fascicles to find the densest fascicle and then moving around on that fascicle to find a nodule. In this case, all we're going to do is sink our fingers down into that area I explained, which honestly is about a fingertip's width. We don't have much more room than that, and we're going to use this upper cervical flexion, contralateral flexion, and rotation to see if we can further stretch these fibers, contralateral rotation, making the majority of these fibers longer, everything except for the obliquus capitis superior. And I can find my fingers just sinking right into some pretty dense tissue up there. And then once I find the most dense or tender spot, I'm again just going to hold for 30 to 60 seconds. How's that feel? Good. All right, and then I can do the other side. Once again, now this hand I'm using as control. This hand I'm going to do that little curved position. Just lay Melissa's head right back over my fingers. I'm going to use a little upper cervical flexion, contralateral flexion to get my fingers in a little deeper, and then I can use rotation a little bit, either contralateral rotation to lengthen most of the suboccipital muscles or ipsilateral rotation to lengthen the obliquus capitis superior. Once I find a nice, dense, tender spot, I'm going to hold that until I get a release, and then of course reassess. Good. Stay tuned for the close-up recap. In our close-up recap of the suboccipital muscles, first step is we need to know where we're putting our fingers, which of course is going to be between that inferior nuchal line and the line we created between the transverse process of C1, which is just underneath the mastoid process here, and the spinous process of C2. The lateral border, we're going to say, of this place we're putting our fingers, we're going to say is the outside or the lateral edge of the transverse process, and then we're slipping our fingers just underneath the inferior nuchal line, which is essentially the base of the skull here. Now to get our fingers a little deeper and put some stretch on these suboccipital tissues, we can do a little upper cervical flexion, which is going to look a lot like retraction of the cervical spine, and lateral flexion. And then from there we can even experiment with rotation. So if I do contralateral rotation, that's going to lengthen the majority of the suboccipital muscles. If I need to shorten them a little bit and get a little bit more slack, I can do ipsilateral rotation. The only suboccipital muscle that doesn't follow that rule of rotation is the obliquus capitis superior. Now, step 2, are there any tissues that could be damaged or insulted or maybe don't like compression? Well, we do have to realize that the floor of the suboccipital muscles here is the vertebral artery. So I would keep your VBI signs in mind. If you're in this position, you can look straight into somebody's eyes and watch for things like nystagmus. If you have them just continue to talk to you, you can notice if there's any slurred speech. And of course, if they feel like nausea or any symptom that's just a little outside the norm, I'd certainly be careful. I've never actually had those symptoms occur. It's just an anatomical possibility. Step number 3, finding our densest tissues, guys. You're just going to go from lateral to medial. I don't think you're going to be able to feel fascicles like we have in other techniques. As I said in the further shot, it's probably not possible to differentiate or reliably differentiate the different suboccipital muscles. So I think just moving from the transverse process of C1 in towards the spinous process of C2 underneath the inferior nuchal line and looking for the densest tissue and holding it until you get a release is probably the most reliable technique we're going to be able to come up with, or the most reliable protocol we're going to be able to come up with. And of course, patient position once again is just supine, and you notice like I get that nice natural curled hand position. I'm holding her head so I can control it real easy, and it's actually the weight of her head that's doing all the work. I'm not like gripping her head, I'm just kind of curling my fingers and letting my fingers sink in where I think she has a point of hyperactivity or increased tissue density. So there you have it. Knowing your functional anatomy will definitely help your manual technique. It'll help you differentiate structures so that you can place your hands where they need to be, as well as make you aware of the sensitive structures around the tissue that you're trying to target. Things like nerves and lymph nodes and arteries. Make sure that if you're going to place your hands on a patient that you have done an assessment and have a good rationale for placing your hands on that patient. And if you're going to assess, make sure you reassess to ensure that your technique was effective and you have a good rationale for using that technique again. Now with manual therapy, one-on-one live education is incredibly important. Please be looking for opportunities like workshops and mentorships and maybe even classes at your local university that can get you some one-on-one individual instruction, or at least some live classroom instruction, so that you've had a chance to be critiqued and mentored by somebody senior to you with some experience in manual therapy techniques. And before you bring this stuff back to your rehab, fitness, or performance setting, please practice on colleagues. There is no substitute for practice, and it is going to take a while to get accustomed to some of the techniques that we show in these manual technique videos. Don't expect to learn them in 2 or 3 or even 5 minutes. You want to have hours of experience under your belt working on various different body sizes and shapes, so that when you do get that first paying client, first paying customer, and you're really trying to make a good positive impact, really trying to promote better outcomes, you feel comfortable with that technique. I look forward to hearing about your outcomes and hearing your questions in the comments section of this video. I'll talk with you soon.